As you know, we're launching a study on remineralization of white spot lesions resulting from taking brackets off orthodontics patients. And so we thought as part of this we should have someone come talk to us about the demineralization, remineralization process and what's involved. And so we're pleased to have Dr. Domenick Zero. Dom is Associate Dean for Research, Director of the Oral Health Research Institute, and Professor and Chair of the Department of Preventive and Community Dentistry at Indiana University School of Dentistry. He's been involved in research for a number of years. His current research interests include the evaluation of the clinical efficacy of topical fluorides in prevention of caries and erosion, non-fluoride remineralization agents, and new early caries diagnostic systems, all of which come into play in what we're going to be doing with this study. So we're very pleased to have him here and look forward to it. Thank you, Tom.
In terms of my background, one thing that wasn't mentioned is I am a general dentist. I was trained at the Eastman Dental Center and to be a sort of a super generalist. Now, I've only practiced off and on over the last number of years because I've gotten very involved with research and administration. But one thing I do want to say is that, part of the reason I've been at research is because when I left dental school, I was trained at Georgetown, which is a very clinically focused school. I have to tell you, I did graduate first in my class. I was a very good clinician. I'm not bragging, but I just want to give myself some credibility with this group. But one thing I realized when I came to Eastman Dental Center is that I knew nothing about cariology. And I think the numbers are something like 70 billion with a big B dollars is spent to deal with dental caries and its consequences, the sequelae of dental caries. So it's a huge problem for our society. And unfortunately, even to this day, dental schools do not put that much emphasis on teaching cariology. And so my career and my efforts and my research have really been trying to understand the disease and ways of improving human health through understanding and preventing dental caries. So my focus is really on prevention. And not that I don't value restorative dentistry and the need for that. So just to start off with a little bit of some definitions. Most of us as dentists really think of dental caries in terms of the caries lesion, which is the second of the two bullet items here. And really, this is really a manifestation of just one stage of caries. As a cariologist, I think about caries as a process which involves an interaction between the dental plaque biofilm and the tooth surface and the subsurface enamel. So there's actually a lot of interactions. It's a very complicated process. I won't go into too much detail about it. But basically, it's a very dynamic, interactive process. But we do know from the literature and from experimental evidence that the very early stages of caries, we can remineralize the tooth mineral, especially the enamel, and to some extent the dentin. And as the caries progresses, we can both remineralize and arrest that process. And then if it progresses further, then we need to use our restorations to deal with managing the disease process. But it's one continuum. It's one disease. There's not two different approaches. Prevention on one side and restorations on the other. This is one process. It's one disease. We need to manage it as one disease. So in terms of the modern management of caries, we're dealing with early lesion detection and assessment. What I mean by assessment is caries activity assessment of the lesion. Is this an early lesion that we see clinically? Is it active or inactive? It's a very important determination. Risk assessment. A number of studies are being done by your PBRN in terms of risk assessment. Then establishing a diagnosis and a prognosis. And then determining the appropriate preventive or restorative interventions, depending what's needed. And then looking at the health outcome of that whole process. And one of our problems is that we really don't assess this as a system. We sort of look at the individual components, but we really don't look at the whole system to really see how effective it really is. And in all honesty, it's really a black box for us. Even though we've been at this for a long time, if we look at the paper by Bader and Sugars, there's tremendous variation in what dentists do and how they decide things. We do know from the literature that there's there's a very high rate of caries, or I should say these white spot lesions that form, and to some extent caries, around orthodontic brackets. And actually, if you look at the range of studies, it ranges from something like 17% to as high as 80% or even 90%. So there's a pretty high incidence of this problem. So I ask you, is this a successful orthodontic case when we see an outcome like this? And my thanks to Dr. Jeff Dean, who's an orthodontist at our school, and our Associate Dean for Faculty Affairs, who let me have this case. And we can see that this is probably a reasonable aesthetic result, and I'm not going to ask the orthodontist in the room to critique this, but from a caries point of view, it's a real failure. And also from a periodontal health point of view, it looks like not necessarily the best outcome. In terms of etiology, the tooth location and the morphology of teeth is very important, and basically caries generally occurs in areas of stagnation, where plaque can grow undisturbed and limit access by saliva, and the caries process forms typically in these locations. And then, of course, we need a cariogenic biofilm, dental plaque, with acidogenic and acidoric properties. Acidoric properties means that the bacteria not only can produce acid, but can continue to produce acid as the pH of the plaque drops down to below the critical pH that demineralization can take place, which is generally thought to be around 5.5, but really there's a range of pHs that demineralization can occur. And then, of course, frequent dietary exposure to fermentable carbohydrates. And then salivary flow rate and composition plays a big role in modifying this process and is really our main protective factor in the human mouth. So in terms of a site-specific disease process, dental caries is highly localized and it's very complex and it occurs in areas of stagnation, as I mentioned, where the biofilm can accumulate undisturbed. Each tooth site represents a unique environment that influences plaque composition, the metabolic status of that plaque, the thickness of that plaque, and the thickness is very important, as well as access by dietary substrates, clearance of those substrates, saliva, and anti-caries agents. So basically, when you have undergoing orthodontic treatment, you're basically creating what could be referred to in the lingo of this gentleman named Phil Marsh, an ecological disaster for that tooth, and that you're actually allowing plaque to accumulate undisturbed, and it gets very thick around these brackets because it's protected. Normally on the buccal or the smooth surfaces of teeth, even without toothbrushing, there's a limitation on how thick a plaque can get. It's usually about 500 microns. But once we have this hardware there and keeps the mucosa from rubbing against the tooth, you can get millimeter thick plaques. And that's part of the problem in this situation. So what are so when I look at caries, I think I said it's site-specific. So I look at what are the modifying factors that can affect the site specificity of caries. Well, the pre-eruptive and post-eruptive fluoride exposure, oral hygiene practices obviously play a big role in modifying the thickness of plaque and how much accumulates on the surface. The actual composition and metabolic properties of the biofilm, including its thickness, is a very important factor that I mentioned. And then access by saliva, its flow rate and its composition. And then there's also pellicle formation. This is an organic film that coats the tooth surface and is in between the tooth surface and the dental plaque, and it has somewhat of a protective role. And then, of course, oral physiology. And then everybody's a little bit different in this regard, and how fermentable carbohydrates get cleared from the mouth, how fluoride gets cleared from the mouth, and it varies in different locations in the mouth, and to some extent explains the site, the difference in distribution of caries throughout the mouth. So to sort of look at this in a little bit more of a cartoon way, we have the composition of the plaque, we have the metabolic state of the plaque, we have the thickness. And a thicker plaque generally is more cariogenic, but not necessarily, because if a plaque is really, really thick, it actually becomes somewhat diffusion limiting. And it actually can, so the carbohydrate has to diffuse through that plaque, and actually has to get from the plaque to the surface. So acid production in a really thick plaque at the surface is not going to affect the caries process. It's really the acid production going on adjacent to the tooth surface that drives the caries process. That holds true for when we think about anything that's preventive. If fluoride gets stuck in the outer surface of the plaque and doesn't get down to the surface adjacent to the tooth surface where the action is, again, that fluoride is not going to be effective. That also holds true for many of the antimicrobial agents, which tend not to be very effective because they have two problems. One, they don't get through the plaque, and two, they don't stay around long enough to do any good. And then the diffusion properties of the plaque. We've been doing some research in this regard, in that if plaque is formed in the presence of sucrose, sucrose tends to produce something called glucan, which is like it's a glucose polymer. And it's a very unique thing with just specifically sucrose in the diet. And this creates actually allows the greater rate of diffusion through the plaque, so that substrates like dietary substrates can penetrate and go deeper through the plaque and get to the tooth surface and cause the problems. So that's a symbol for carbohydrates. Acid is produced, and then that acid then diffuses and attacks the tooth surface. And we'll get into the details about the demineralization process in a second. Another important parameter is the degree of saturation of the plaque and the plaque fluid. That's the fluid phase of the plaque itself. That's the fluid that interacts with the tooth surface per se. The cells of the bacteria really aren't the problem. It's the fluid phase in between the cells that drives the caries process. And so in terms of degree of saturation, and calcium, phosphate, and fluoride in that plaque basically has a protective role, because through a common ion effect with the calcium and phosphate, it basically slows down the demineralization process and actually can shut it down if enough calcium and phosphate build up in that plaque adjacent to the tooth surface. And we know about fluoride and its protective role, which I'll get into a little more detail later on. So in terms of saliva, we also have site specificity in terms of proximity to the salivary glands. We have different salivary film thicknesses in different areas of the mouth. And the work of Colin Dawes in Manitoba has been very instructive in that regard. We also have something called the salivary film velocity, which is the rate of fluid across the tooth surface. And that's very important in clearing away the carbohydrate and the acid. So the faster the salivary film velocity, the faster we can basically neutralize the caries process. And then pellicle composition will tend to be, which is mainly driven by salivary components, will also be variable throughout the mouth. And its thickness of the salivary pellicle also varies depending upon location and mostly abrasive forces. So, when I think about orthodontic treatment, of course, we don't use bands as much as we used to, but one of the models that was introduced by Ogard, who's a orthodontist who's also a cariologist, was he would induce caries by using these bands. And the way he did it is he created a little spacer here between the band and the tooth surface, and within about 4 weeks, you can get significant and aggressive demineralization of the tooth surface. I don't know if that shows up very well, but basically that's a pretty extensive area of demineralization caused by food packing in there and bacteria producing acid, and then being cut off from saliva's normal protective effects. So one of the points I do want to make today is that all patients with orthodontic appliances are high caries risk patients until proven otherwise. In other words, some of your patients that you're treating orthodontically do not develop this problem. But I think with the high incidence of this problem, you have to treat them, at least to start, as all high-risk patients, and I think they should be given and managed by high-risk protocols. So the next feature of the caries process is that it's a time-dependent disease process that is modified by protective factors. So our historical understanding of caries goes like this. Fermentable carbohydrates, producing acid by the biofilm, leading to breakdown of the mineral of the tooth, leading to caries. And the way it worked was dental caries, restoration, larger restoration, endodontics, extraction, prosthodontics. So basically, that's basically the life cycle, and that's pretty much what dentists do to a large extent. I think this is very good for dentists, but maybe not the best for patients necessarily, because I think some of this cycle of caries, restoration, re-restoration, larger restoration can be broke by more aggressive prevention. So the other point I wanted to make is that our profession is heavily biased towards our successes. So when you go to most of your continuing education courses, you get to see all these wonderful treatments, right? And all these perfect results. And we tend not to talk about our failures And I think that also creates a certain bias in the system. We do that definitely in the education of our dental students, I can tell you that. So the modern understanding is, again, an understanding of the caries process, and that the conditions that the dye creates in the plaque as we undersaturate the fluid phase of the plaque, which leads to demineralization, that by removing the dietary challenge or increasing salivary flow and fluoride, or perhaps, and I say perhaps, introducing more calcium and phosphate, we can basically change the cariogenicity of that plaque and drive it back to a more supersaturated state and lead to remineralization. And we know that fluoride plays a dramatic role in modifying both the demineralization process. The early stages of caries may be prevented or reversed or arrested primarily through elimination or modification of the etiological factors and or enhancing the protective factors. And fluoride sealants and salivary stimulation are the most evidence-based approaches that we do have at hand right now. Okay, in terms of the actual demineralization process, this is a study that was done by Dr. Ando, who's on my faculty. And basically, if you expose a tooth for 4 hours to acid, that's somewhat artificial because typically we don't, well, that's not so artificial. If someone's drinking Mountain Dew continuously, they're getting exposed to acid almost continuously throughout the day. So this is, maybe it's so not so unrealistic when I think about it. So after 4 hours, we get this initial surface softening and these kind of microchannels that sort of extend down, or the acid is diffusing from the surface down. Remember, caries occurs from the surface down. Keep that in mind. At 8 hours, we see a thickening or a deepening of the mineralization with further mineral dissolution. At 12 hours, we start seeing, in fact, a reformation of the surface layer to a certain extent. And after 16 hours, again, we see more demineralization, and again, that surface layer seems to build up even a little bit more. So that's how we come up with the so-called non-cavitated white spots, basically through this process. It's a fairly good demonstration of how this can occur. And but I do want to make the point that a lot of people like to use the term an intact surface layer. That is wrong. The surface is not intact. It is actually partially demineralized. It's actually very porous, and that allows the acid to diffuse through the surface and attack the more soluble subsurface enamel, and that's where the lesion. So, and the reason why the surface layer reforms is because as the body of the lesion, as the mineralization is occurring right now, the mineral, for caries to occur, has to go somewhere. So it has to go past the surface to get out into the saliva and into the oral environment. So what happens actually is it reprecipitates on that surface, and that's one of the reasons the surface stays intact. There's other reasons, and a lot of it has to do with the dynamics that goes on between the biofilm and the buildup of calcium phosphate at the biofilm interface, as well as the effect of fluoride. Fluoride mainly interacts with the surface layer. And I'm going to talk a little bit later on about low fluoride concentrations versus high fluoride concentrations, because that's a topic that seems to be of great interest to orthodontists, and we'll get into that in a little bit more detail. So this is what the surface layer looks like. So does that look solid to you after it's been demineralized? It's very porous. And basically you have all these little diffusion channels that allow the acid to diffuse down from the surface down. And if you magnify that, it looks like a sinkhole pretty much. So that's how the acid gets past the surface down to the deeper enamel. So then we wind up with this sort of clinical appearance of a white spot. And basically the reason it appears white is because when we get this subsurface demineralization, it changes the optical properties of the tooth, so that when light, enamel is very translucent normally when it's sound and intact. So when light passes through the enamel, it basically scatters. When it scatters, it basically puts off the full spectrum of light, and basically what comes back to your eye is white light. That's what you see. When light, an intact enamel, normally the light transmits through the enamel, and basically it looks translucent. You don't see the whiteness. So that basically explains why white spots or the subsurface lesions look white. And again, this illustrates the fact that the surface layer for these white spots tends to be, it has some areas of intactness, but it also tends to break down. And you actually, the other point I want to make here, using this as an example, is that you actually see surface erosion. So part of the caries process is actually loss of some of the surface. And you can see this when you study the early phases of caries on surfaces. You actually get like a little indentation in the enamel. So that surface is not intact. This actually is being eroded to a certain extent, as well as there's areas where you actually have very thin. And once this breaks through, then you're into a cavitation, and then caries process accelerates greatly. And to sort of illustrate what's going on is if you look at sort of the normal eating habit of the average American here, where they constantly graze all day long, you basically have demineralization, remineralization, demineralization, remineralization. So every time the pH of flat goes down, you get demineralization, the pH starts rising, you get some remineralization. So at the end of the day, you're going to get some net loss in mineral. Now, if this continues over many, many, many days, eventually you're going to get a cavitation. In patients that have decreased salivary flow or continually expose themselves to fermentable carbohydrates like Mountain Dew, then you're going to get more demineralization, and that caries rate is going to be greatly accelerated. If we project this out over the years, when teeth first erupt in the mouth, teeth are most susceptible to caries when they first erupt in the mouth. They go through a post-eruptive maturation process. This is a great time to get fluoride on teeth. As a matter of fact, one thing that sort of troubles me about how we use dental preventive services, we sort of do it every 6 months. We should really concentrate our preventive services at a time when it's most needed, and that's in children when their teeth are going through active eruption. And then, then there's other periods where things are more quiescent, and we don't need to be as intense. That's a smart system approach, but we're not really doing that right now in dental practice. So teeth go through a little bit of a maturation process. They actually acquire mineral, and then they can start demineralizing over time with a metabolically active biofilm. And then we can get to the point where we can actually see these clinically as white spots. And then they can course on and become cavitations of the time, or we can actually arrest the lesions at this time. So the question is, can we ever bring teeth back to here, to the point where they started? No, we can't. There's no evidence that we can remineralize teeth back to where they started once they've been demineralized. So let's just make that very clear up front. We can do it in the lab, under nice, clean systems where everything's perfect, but in the human mouth, for lots of reasons, which I'll explain later on, we can't do that. So again, looking at this whole process again, taking this diagram that Silverstone published years ago and made popular. We have the different zones of caries, the so-called relatively intact surface layer, and then the body of the lesion, and the dark zone, translucent zone. But I'm going to use this to sort of illustrate what's going on here. We have the acquired pellicle coating that surface, which is actually somewhat diffuse and limiting. It limits both acid from penetrating the surface, but it also limits calcium and phosphate from penetrating the surface. So it has a dual role, one positive, one negative. So as we accumulate plaque on the surface, that's producing the acid. Once it comes in contact with fermentable carbohydrates, and the acid then diffuses through the surface into the body of the lesion where it causes the demineralization. And if we can get remineralization going, we have to, again, diffuse through the pellicle and then remineralize down in the body of the lesion. It's very hard to do that. Most of what happens, what we see clinically, is happening at the surface layer. The remineralization is mostly happening at the surface layer. And that is the reason why most white spots don't necessarily disappear once they're formed. They can get a little smaller, they can be abraded away, but they rarely remineralize completely. And I'd like to talk to you folks a little bit later on about your clinical experiences in this regard, because I need to learn more about that. So let's move now from demineralization to remineralization. First of all, I mentioned that teeth are at greatest risk when they first erupt, and they undergo a post-eruptive maturation process, which is sort of a remineralization process. They acquire more fluoride. Once they erupt in the mouth, they actually acquire more inorganic material. They also acquire some organic material, which is somewhat protective in the form of the acquired pellicle. We mentioned how this process is dynamic, and it can reverse and be arrested at various stages along the way. I mentioned that we can remineralize teeth in vitro almost completely, but in vivo it's a much slower process, and we can never achieve complete remineralization. Let me qualify that. At the clinical level, when we see a white spot, that is too advanced to expect ever to get complete remineralization. What's going on every day in our mouth at a subclinical level is we're partially demineralized enamel crystals. We can remineralize them almost completely on a daily basis. That's before it gets too advanced as it does. You know, for a cariologist, a white spot is a relatively advanced lesion. Just want to make that clear. There's a lot going on before we get to a white spot stage. And the very, very early stages of caries can actually be remineralized. That's how fluoride works in general. It basically prevents lesions from ever getting started. It shuts them down at a subclinical level, but it also slows down lesions from progressing, and that's why we see some white spots in the mouth, and probably see a higher incidence of white spots in the mouth since the introduction of fluoride. But we're also shutting down the actual clinical incidence of caries as well in terms of actually seeing it in the mouth. Yes?
So when you talk about remineralization, how many microns are you talking about?
Okay, for a white spot to be clinically evident, it has to be about 200 microns deep. That's pretty deep, well, at least from my perspective, because I'm usually studying things in the very, very surface. So, to remineralize all at 200 microns is very difficult. So is that the perspective you needed?
Yeah, and if you etch an enamel for a composite filling, how many microns?
No more than 5 microns. Basically, you can surface soften up to about 10 microns. So when I also do research with dental erosion. Dental erosion is just initially a surface softening that occurs, and it only penetrates down 10, 12 microns. Once you get beyond that, then you get into a whole different kinetic, and that actually leads to the subsurface lesion formation. But you need a plaque for that to occur. It will not occur. It doesn't occur with dental erosion. It's just purely a surface phenomenon. Okay? We also know that individuals vary greatly in their remineralization capacity, so not every patient is going to remineralize the same. And I do a lot of work with these I'll show you one of them later on, in-situ models, where we actually put pieces of enamel in the mouth. And we see tremendous variation in our subjects, where some remineralize very strongly, some remineralize hardly at all. Some are very responsive to fluoride, some are not very responsive at all in terms of remineralization. And when I think of dental caries, and I think of the main mechanism of action of fluoride, I think of remineralization. When I think of dental erosion, I think of demon inhibition. And that's something that I've come to very recently because, as I said, I continue to be a student of all this. Another very important point is once we repair enamel and reharden it or remineralize it, it's actually more resistant to subsequent acid challenges than intact sound enamel. So one of the things that some dentists like to do is when they see a stained tooth surface that has had caries, it's sort of a scar. They don't like the way it looks, so they sort of question whether it can progress, and they get out the little burr and they remove it. Well, you're actually removing something that is actually more resistant to caries. You're replacing with a filling material that's going to break down over years, have to be replaced, and it also has margins, which makes the tooth more susceptible to caries. So in fact, when we take out arrested lesions, unless we're doing it purely for cosmetic reasons, we're really doing the patient a major disservice. Yes?
Could you clarify the two statements that I'm having trouble putting together here?
Sure.
There's no evidence that enamel can be remineralized to pre-lesion resistance to caries.
That's correct.
And
as far as I know, and I've looked for it.
Remineralizing the lesion makes it less susceptible to caries than it was originally?
Yes.
How do those two statements coexist?
Well, you're thinking in terms of this beautifully formed enamel that is perfectly formed that's going to prevent acid dissolution. It doesn't exist. Even enamel which is pure fluorapatite, as much fluoride as you can put it into the tooth structure, which is 40,000 parts per million, which is basically shark enamel. It's pure fluorapatite. You put that in the mouth, you put a plaque over it, it demineralizes. There's no such thing as a perfectly formed enamel. So I don't care how much biotechnology we're going to talk about right now. If you put it in the mouth, it's going to demineralize under the right conditions. Now, you can make it less soluble. So what's really going on, and I'm going to talk about this in a few seconds, is there's like an adaptation process that takes place. When you demineralize enamel and then remineralize it, the crystals that form are no longer prismatic. They're more disorganized. It's really called aprismatic enamel. That's one thing. They tend to be larger, which means they have less surface area, relatively speaking, which makes them less reactive to an acid dissolution. They acquire more fluoride, which makes them less soluble. And they also acquire more organic material, which actually protects them from demineralization. So those are the main things that happen with the adaptation process that occurs in the mouth over time.
Thank you.
You're welcome. Good question. So most of the evidence that we have about remineralization comes from a heavily quoted study by Bakadurks in 1966. This was a very interesting study where they examined the upper first molar of 8-year-olds and then re-examined that surface when they were 15-year-olds. And you can see the transitions that can take place between sound enamel. Some of the sound becomes a white spot. Some of the sound actually becomes cavitated. And white spots can sort of become sound. They can stay the same, or they can become cavitation. So that's basically most of the evidence that people cite to justify this whole concept of remineralization, because 37, almost half the white spots disappeared. If you read the article, and don't just accept the data for what, just the data, there's a clear statement in the article that the authors do not know whether that was really remineralization or these white spots which actually brushed away. Okay, so once you soften enamel, its susceptibility to toothbrush abrasion or any of the abrasive forces, whether it's demastication, which is food abrasion, or toothbrush abrasion, or even the mucosa rubbing against the tooth, the enamel is the hardest substance in the body. Once you soften it, it becomes very susceptible to wear. So you basically can brush away your caries, literally. So what happens when a tooth's erupting, the plaque accumulates at the free gingival margin, and then the tooth erupts a little more. And now that area where you had the act of demineralization is no longer in a cariogenic area, because you're now, the free gingiva has moved further down the tooth or further up the tooth towards the root, and now it's no longer subjected to that same cariogenic plaque. And so then it basically is soft. You get better access to it. You can brush it away. So this is what we have, pretty much. And this study is constantly quoted. But again, if you read the article, it's not very clear whether this is true remineralization. If you look in the literature, there's all sorts of terms for remineralization. There's remineralization in terms of research terms: mineral deposition, mineral reprecipitation, decreased lesion depth, mineral gain, rehardening, decreased porosity. These are sort of terms we use in research mainly. Clinically, you have arrested caries, caries reversal, rehardened lesions, lesion repair, lesion consolidation, lesion healing. So in my mind, there's a lot of confusion around what remineralization really is and what we should expect. See, I actually believe a good outcome for a white spot is arrest it, keep it from progressing. That's a good outcome. Of course, if it's a patient who's been treated orthodontically and they have these white spots on their prominent anterior teeth, that's not a good aesthetic result, and I understand that. But from a cariologist's perspective, it's a good outcome to arrest these lesions, keep them from progressing. So just to illustrate how, remineralization, I work with these in-situ models where we basically cover enamel specimens with gauze, and then we study them study their hardness using a surface micro hardness tester. We do studies where we measure the baseline hardness, we demineralize them in the laboratory, and then we remineralize them in situ in the human mouth usually for 2-week periods. It could be 3 weeks, 4 weeks, whatever. But just to illustrate that over a 2-week period, you actually get some remineralization of these partially demineralized enamel, just putting up them back in the mouth. You get about 10% recovery in hardness. If you increase the fluoride concentration of the dentifrice, you get about a 40% recovery. I've also done studies with much higher fluoride concentrations, up to 2,700 parts per million fluoride, and I can remineralize up about 50-60%. But that's as far as I can go in the human mouth with these partially demineralized enamel. So I'm never able to remineralize the teeth, even under these carefully controlled experimental conditions using these appliance systems. Yes.
So you demineralize it for 100 microns and you're able to
No. With hardness testing, we can't demineralize very deep. So the lesions are only about, at the very most, 25 microns in terms of they're just surface softened. They're not white spot lesions, you're just surface softened. So they're usually about 25 microns of softening that occurs. So they're very superficial. These would be subclinical demineralization.
So when you say 50%, you mean 12 microns of remineralization. If you say 50% of remineralization, does it mean 12?
Well, it's recovery and hardness. I can recover back 40% of the original hardness that the tooth had at baseline. Okay? So clinically, we can arrest, remineralize, but notice that it's not white. it's brown. These are called brown spots. In this clinical situation, what occurred here is the first bicuspid was extracted. Once the first bicuspid was extracted, we've changed the oral environment. We have better access to the toothbrush and to saliva. We've arrested the lesion. But that is not a pearly white tooth. It's actually acquired a lot of organic material. The reason it's organic, I know it's organic, is you can't stain pure hydroxyapatite. You can only, it's organic material that acquires the stain. So that's what we're seeing there. It's actually a consolidated lesion. It's arrested. If you took this tooth and you put it in acid, the sound enamel around it will dissolve, and that one area where it's arrested will stay intact. It's the most resistant part of the tooth. So when you go in, you may want to do it for aesthetic reasons, but if you're doing it for disease prevention, you're not doing the patient any good. And I can tell you that right now. Now, teeth can arrest even at very advanced stages. I'm not saying this is a good clinical outcome, but after an extensive caries process, to the point where the cusps were completely undermined and they broke away, once the dentin was exposed to saliva, it basically becomes, it consolidates, it remineralizes, it acquires organic material, becomes very leathery, not soft at all. And this is the patient I saw clinically, so I know it was hard. There was no caries there at all. Again, it's not a good clinical outcome. Now, this is a patient that had orthodontic treatment. Her father owned a pizzeria, and she drank Mountain Dew continuously all day long while she was working. And this is how she presented and had to be debanded. And the clinician, Dr. Judy Chin, who's on our faculty, she's a pediatric dentist, she provided this case for me. And she actually used, in some of the areas, glass ionomer to repair the defects. But she was able to observe in certain areas, maybe remineralization, maybe brushing away the caries. It's hard to say. It's really hard to say. But basically, it's a much better clinical presentation than when the patient first. And in this case, what she did is she put the patient initially on Prevident rinse, because the patient's teeth were so sensitive she couldn't even brush, and then switched her over to Prevident gel toothbrush. Yeah, toothpaste. I'm not a big fan of Mountain Dew. Do you get that, the drift? That's a good question. It's two things. It has a high level of sugar in it. It has a high level of caffeine. That combination, in my mind, is addictive to kids. And then the advertising that's behind all this. The kids don't stand a chance, unfortunately. You know, I can tell you, in Indiana, we got legislation going on right now before the IDA, the board, to come out with very strong statements about soft drinks. I mean, I sometimes think our society is, you know, you never see the movie Planet of the Apes? You know, they pick up the Coca-Cola bottle. That's it. That's what did us in. Anyway. All right. Did I answer your question? Oh, let me finish. I'm sorry. I got some. So the sugar, if you have poor oral hygiene and sugar, you have a thick plaque, you drive the sugar through the plaque so it's close to the tooth surface. The acid gets produced down there. Once that acid's produced, it doesn't come back out. It just attacks the tooth surface. So the concentration of the sugar is important. And the frequency of exposure is important because saliva can't wash it away and remineralization can take place. So you're constantly getting demineralization all day long. The acid in Mountain Dew, because it's also acidic, it has citric acid. If you have a plaque-covered tooth surface, the citric acid is not a factor. However, if someone's drinking Diet Mountain Dew or regular Mountain Dew and they have clean teeth with no plaque on it, then you have to worry about dental erosion. So it's a double whammy. But it's not both at the same time. It's either caries or erosion. The sugar, caries, the acid, erosion. Okay? And we're seeing acid erosion in kids. That's a whole other topic that I could talk about another time. So what are some of the factors?
Excuse me, just for a sec. It's not particularly the citric acid or the phosphoric acid that's in those soft drinks. It's the carbonic acid is what rips those things apart.
I'm sorry, I have to disagree with you. The studies that have looked at carbonic acid, carbonic acid is very weakly buffered. And so carbonic acid is in seltzer water. It's not erosive. The studies have looked at it. It's not erosive. It's too weakly buffered. It just, it has a low pH, but then the minute it hits the mouth, it gets neutralized by saliva. It's the stronger acids, the things that have a higher total acidity, that are buffered at a lower pH that drive the equation. The additional thing with citric acid, it also is a chelator. So not only does it attack the tooth surface with the acid, it also complexes the calcium. And so the calcium doesn't build up to sort of prevent further demineralization. So it just keeps on producing demineralization. That's a whole other presentation.
It is. And Utah ranks #1 in the United States in the amount of soda ingested on a per capita basis. And we literally destroy our teeth in Utah. And it doesn't make any difference if it's diet or regular soda.
I agree with you.
It is, and it's that proton that comes off of that carbonic acid that just rips teeth apart.
I'm not sure about that, but I'd love to see the data.
Yeah.
That's all I'll say. So the number of factors that can modify the remineralization process. I mentioned the tooth itself in terms of its fluoride, whether it's enamel or dentin, the acquired pellicle, the biofilm itself, saliva, diet. So the diet can affect two ways. If you have constant acid production in the plaque, you're not going to get any remineralization. But also food itself has some protective factors, and that milk is a great thing. Kids don't drink milk anymore. Milk is protective to teeth. I just want to say that. Milk is protective to teeth. It has calcium and phosphate in it. It has casein and phosphoproteins. It's very, very good for teeth. Except when you put chocolate in it, and then it's less cariogenic. I mean, it's a little more cariogenic. My kids drink chocolate milk, so. So what are the remineralization strategies? Fluoride. I can almost stop there right now, but I'll continue. Salivary stimulation, possibly. Diet modification, possibly. If we neutralize the acid production, we should be able to switch the balance towards remineralization. Then we have the other remineralizing agents, which are the subject of the study that's under consideration with this group, which I think is an excellent study, by the way, and it really needs to be done. In terms of,
Sorry, am I hearing correctly then, or understanding correctly, that to have a patient just rinse with a fluoride rinse, though, if they have the pellicle, et cetera, in the way, it's not helping?
no, it can't help. It's just that the pellicle modifies the effect. This is the mouth, and the pellicle is going to be there. It just modifies the benefit to some extent. But it also protects the tooth surface as well from erosion, as well as just from acid from caries. So it's a little bit of a trade-off. I'm not saying remove the pellicle, by the way. So fluoride has to be at the top of this list. But if we look at the level of interest by a lot of clinicians, the more interested in these remineralizing agents they are in fluoride, to a certain extent, not completely. So I think we have to let the data speak here. That's the way I like to approach it. We don't have a lot of evidence. I'm going to summarize this slide. We do not have a lot of evidence about remineralization. We have a lot of evidence on demineralization. We have very little evidence on remineralization, even for fluoride, at least according to Jim Bader. But we know that Jim doesn't like anything. He thinks that nothing works. Okay. There's a tremendous amount of variance in in terms of topical fluoride. But I'm going to try to just make this really simple. For high-risk patients, concentration is extremely important. And I'm a big fan for high concentration products. Based on the literature review, I think the best evidence right now is for fluoride varnishes, although there's also reasonable support for the APF gels as well. One thing I do have to mention is that anybody who's applying GelCam, which has the same fluoride concentration as toothpaste, is really ripping off their patients, okay? It has the same concentration. The stannous ion has somewhat of a protective effect, but if you look at this just from a pure concentration point of view, you know, send them home with a fluoride toothpaste. Don't put it on their teeth in practice. Give them high concentration, because we know there's greater efficacy with that. Again, I'm going to move quickly. There's a lot of good evidence supporting the efficacy of fluoride varnishes. I was part of this evidence-based clinical recommendation. It was a great process. The ADA is doing a fantastic job. I have the old version of this. Julie showed you the new version, which is great. This is like, you know, who can read that? And then what you showed was really good. I'm very impressed by that. That's great. You know, she showed that one short version, which is color-coded and all that. It just sort of summarizes all this stuff. It's fantastic. In terms of studies, and now focusing on orthodontic patients, again, we're seeing that with, in this case, we're talking about fluoride protector, which is actually has one of the lowest concentrations of any of the fluoride varnishes, which is only 0.1%, which is, again, just the concentration found in toothpaste. But it has this added benefit, and it's a polyurethane varnish, which actually offers some protection just from the varnish itself, unlike some of the other fluoride varnishes. But we can see a definite benefit in both the reducing the incidence, the prevalence as well as the incidence of orthodontic-induced caries. In terms of the home products, again, concentration is important, I think. Although I have to say, from an evidence point of view, there's not a lot of evidence to support Prevident and the other higher concentration products. But based on our understanding of fluoride's mechanisms of action, I'm still comfortable making a recommendation that we do need to prescribe fluoride concentrations at higher concentrations than regular toothpaste. And what we're doing now at our school is we recommend for our high-risk patients that they brush with their regular toothpaste in the morning, and they brush with a high concentration gel before going to bed. Don't rinse, don't spit. Spit, don't rinse, and then go to bed. Fluoride works, fluoride dentifrices work. Fluoride dentifrice we do at the Oral Health Research Institute, we test pretty much every toothpaste on the planet. Not all fluoride toothpastes are not created equal. Many of the newer products that have all these claims for marketing purposes or whitening, brightening, some of these get in the way of fluoride efficacy. I just want to make that very clear to you. Not all of them, but some of them do. And so for high-risk patients, they really need the cleanest fluoride delivery possible because most of the other stuff is just marketing, as I said. How to choose? I typically choose things that are simple, you know, that I know can release fluoride in my mouth. It's the fluoride ion that works. Getting the fluoride in my mouth, the fluoride ion is the best thing we can do. In terms of understanding, you know, how toothpaste work, there's an application phase, which is the concentration of fluoride that you can get in your mouth as you're brushing, and then the retention phase, which is keeping the fluoride in your mouth over a protracted period of time. And so a lot of behavioral things come into play in modifying the retention phase. Just to show you how complicated, we're doing a lot of research right now looking at the kinetics of fluoride in the mouth and what modifies fluoride efficacy. And so obviously the concentration of free fluoride ion is the biggest thing. Brushing frequency is obviously very important, and there's good literature to support that. Brushing effectiveness. There's probably an interaction that goes on between brushing effectiveness and fluoride effectiveness in the sense that if you have a really thick plaque, fluoride's going to have some trouble getting through it. So if you can thin out the plaque a little bit, it's going to work better. Keep in mind that fluoride, when you brush your teeth with a fluoride toothpaste, it works on the plaque that stays in your mouth. It doesn't work on the plaque you remove. Because if you're removing the plaque appropriately every day with your brush, you don't need the fluoride. You're not going to get caries. It's the plaque that remains. And so it's the fluoride's ability to actually get into that plaque, get through that plaque, and get to the tooth surface. That's how fluoride works in terms of fluoride dentifrices. We know that rinsing behaviors, there was a poster out there saying that not rinsing after brushing was associated with an improved benefit. That fits the literature, and it's actually a good recommendation for patients not to rinse out, just spit, and then go from there. We know that fluoride oral architecture modifies fluoride retention. I talked about post-brushing behaviors. And timing, do you brush before or after meals? I think that you brush after meals, and the reason I say that is because we know that fluoride, mainly its benefit in terms of preventing dental caries is in terms of remineralization, so I want to get the fluoride in after I have a cariogenic challenge. We're also doing some research showing that the amount of fluoride you put on the brush is very important. So this pea-sized recommendation, I think, is okay, but for high caries risk patients, even children, I'd much rather they have less caries than less fluorosis. I think we've oversold this fluorosis thing tremendously, and I think the main thing is preventing caries. So it has to be risk-based, of course. Kids that are at high risk of caries need to get more fluoride on the toothbrush because, as I said, the downside of fluorosis is much less a problem than the downside of caries in terms of aesthetics or anything else. Also, the length of the brushing time. We're doing some research showing the longer you brush, the better the fluoride efficacy, which makes sense. Okay, I just want to summarize that if you look at the recommendations that are out there and the reviews that have been done, which I don't think are all that good, we have very weak evidence right now for any of these recommendations. And the whole concept of the fluoride mouth rinse versus the higher concentrations, I think is actually wrong. In my review of the literature, and I'm just going to run through this, if we think about a low fluoride concentration versus a high fluoride concentration, low concentrations basically can do the things we want it to do, decrease the mineralization and increase the rate of remineralization. Those are the main, but an increased rate of enamel remineralization is the main one I focus on. But what are high concentrations doing? Most important thing, and I got to bold it here, is the high concentration provides the driving force to get the fluoride through the plaque. So the plaque that the kid's missing, or the adult's missing, or the orthodontic patient is missing, high concentration allows the fluoride to get through the plaque to the tooth surface where it needs to work. Makes sense, right? Sort of? So this whole concept of using a low concentration because we want to remineralize the whole lesion is bogus. It's just totally bogus. I don't know how that snuck into people's minds, but it's wrong. And so we have John Featherstone's study showing that a fluoride mouth rinse can be effective, but this study doesn't have, it really, the model is a model, and it's not really a clinical outcome. So I'm not going to, I think this is an okay study, but I think I want more, I want data closer to what's happening clinically. I'd rather not deal with extracted teeth as he did in that study. I want to look at some clinical evidence. And here's another study that was done by Alexander and Ripper, which really looked at, which compared the rinse and the high concentration and showed the high concentration was more effective. So I go with this study right here. I just trumped the other study with this data. In terms of studies done, again, with in-situ models, again, looking at this concept, low concentration versus high concentration. Both low and high concentration was able to remineralize through the depths of the lesion. And again, these are laboratory-induced lesions. And they concluded that a high concentration did not block the inward diffusion of fluoride into the lesion, and they got better efficacy, better remineralization with the high concentration. So again, that tells me high concentration is where we need to go with this patient population. Again, here's another study looking at does low concentration work better? It didn't work any better than control. So it really didn't do any good. So a takeaway point here, and a very important point, is when we deband the patient, those teeth are going to tend to remineralize anyway, doing nothing. Just changing the oral environment by taking the stagnation areas away, those teeth are going to remineralize naturally to a certain extent. We got to keep that in mind. So when you see data that's generated by a company, but they don't have a proper control, and they show you're getting a benefit from whatever product, you disregard that data, because it's not, without a proper control and proper randomization, you can't believe that stuff. All right, I'm going to skip. Oh, first of all, rinsing is a problem with compliance. I'm just going to run through this. The current, I really want something other than fluoride, because it would be great to have other tools out there, but right now the data isn't strong enough for me to accept this. With 2 reviews looking at the evidence, the problem with the recaldent data is that it's all the positive evidence comes from one group, and then everybody else out there is not finding it, including me. So we have to be very careful. I know you're running a study. This study really needs to be done. It really needs to be done, and it has, and it's a well-designed study, and I just want to commend the investigators and the study dentists for really doing the study. And I want to, if it's not fully enrolled, I want to get other people excited about enrolling for this study, because it's an important study that needs to be done. First of all, it's much better to prevent demineralization than to try to remineralize the damage, because you can't fully remineralize. All patients undergoing orthodontic treatment must be considered at high risk until proven otherwise. All patients should be carefully examined at each visit for early signs of demineralization. In other words, I think that it should be a standard protocol that every patient's teeth are examined, whether it's at 8 weeks or 10 weeks or 6 weeks, it doesn't matter. They should have their teeth cleaned, and the tooth surfaces should be examined very carefully for signs of demineralization. And that all patients, again, should be put on a high-risk preventive regime, except for the patients in your study, of course, because that has to be controlled. I'm going to stop there, and I apologize for going over. You've been a great audience. I really enjoyed the questions and the interaction. Thank you very much.